the way it's been delivered in any nation. And today we are going to be taking maternal health from an interesting perspective, which is the use of analgesia in management as regards childbirth and labor. And joining us to this subject matter is Dr. Julian Ojebo, a consultant anesthetist in Garki Hospital, Abu. Good morning, Dr. Ojebo. Can you hear us? Dr. Eros, kindly unmute yourself. Good morning.
Good morning, I can hear you.
Great. How are you doing?
Very well, thank you.
Great. So like you know already, maternal health, and we're talking the use of analgesia and options to have in as regards pain management during labor. So just explain to us in very clear terms, what exactly is analgesia? Hello, can you hear us, Dr. Jebo?
The network wasn't so fantastic.
What is it?
Okay, so thank you very much for analgesia. Simply put, is anything you take so as not to feel pain. Okay, every woman of reproductive age that conceived the child, once this woman comes to term, the woman has successfully carried that child in for a period of 40, between 36 to 40 weeks, that woman comes to term. For that woman to let down that child, the woman has to go through pain. Okay? Prior to now, we always believe that women are not supposed to have anesthesia, and they say bear the pain, it's going to come off. Every woman is up to that. But ideally, that is not what it should be like. Okay, you're supposed to have analgesia so that you don't feel pain in the process of letting a child. We can give birth vaginally or sections, right? When you want to give birth through cesarean section, they give you some medication so that you don't feel pain while they're doing the procedure. But oftentimes, forget that the woman that is also trying to push down a baby should give pain medications so that she doesn't feel pain. Okay, so generally, over the years, these analgesic options have moved from just psychotherapy to doula birth, to massages, to emotional support, to what are pain medications. Okay. Now, these interventional pain medications, epidural in labor. Any woman that has an epidural should have an epidural just at the labor pain. So the obstetrician will tell you that once you are 3 centimeters to 4 centimeters of dilatation, you have this epidural instituted. So the epidural analgesia is like we are sticking, when you want to stick a needle in the hand of them, drips, drugs, and all of those. Now, this time is different. We're sticking, okay, just closer to the lower, we call the lumbar region. Okay, so
okay,
that this
doctor, you're talking about women who are probably going through a cesarean section.
No. Any woman going through
Go ahead.
Any woman going through pain, labor pain, woman going through labor pain should have analgesia. Whether you are doing cesarean sections or you're giving birth normally, which we call vaginal birth, you should have analgesia. So that's where we are now in scheme of things is what we call the epidural analgesia. Can you hear me?
Yes, loud and clear. Go ahead.
So that epidural is instituted at the back of this woman, and then medications will be given through a small thread catheter. Okay, and she'll be having drops of drugs that are being carefully pre-calculated so that there's and lesser side effects for these patients. So that is where we are now. Where we are it's called labor analgesia.
All right, Dr. Jebo, what you just now sounds pretty invasive, where you have to administer through the patient's spine. Are there other types of anesthesia that could be administered in ways that are not so invasive but still as effective? So, can you hear us?
Yes, I can hear you now.
Did you get the question? Okay,
no, I didn't get that.
Yes, I said epidural administration that you just explained to us now sounds invasive to me, in the sense that you have to administer this drug to the patient's spine. And I'm asking, are there other means of administration that are less invasive but as effective as the epidural administration?
Yeah, thank you very much. Like we say, it's all about effectiveness and safety. For every procedure we do, it's about the effectiveness, the procedure we're doing, and how safe is that procedure and to the child. Okay? Now, there are other non-invasive procedures, okay, used for labor. But how effective are they? The effectiveness in terms of, does it cause the woman to sleep, the child to sleep, while giving less analgesia? Okay, prior to now, what we used to do was administer an opioid. One of the drugs we give is to administer, the commonest one we use is the fentanyl. These drugs, they have the ability to make this child some form of respiratory insufficiency, some respiratory problems. So we've moved from these less non-invasive procedures to minimally invasive procedure. This procedure is actually minimally invasive. Right hands. That is why, as an obstetric anesthetist, over 100 plus of them in the span of year or so. So these procedures are less invasive or minimally, okay, in the hands of the right provider.
All right, Dr. Jebo, so I'm pretty curious. I mentioned earlier that people feel child pangs or child is normal and natural, therefore a woman should go through those birth and pains. So what are the challenges you have found, given your experience, in trying to administer these pain relievers or analgesics to? Did you have to get the consent of the partners or the husbands or parent, really just go ahead and administer based on your medical discretion?
Okay, so you've asked a lot of questions in one, right? The first one, from the end. For every procedure, even to set up a line for you, I need to take, okay? I need to explain the risks and the benefits to detail, so as for you to make an informed choice, okay? We're not in a banana republic or a zoo where people just, grab a patient and then just institute things on the patient. Do that, okay? So we take informed consent, and this consent is actually biphasic. There's usually the verbal consent. We come to explain in details to you the risks and the benefits, and then we also have what we call the written consent. The written consent, you now sign, append your signature to that free will, voluntarily, I have said that procedure should be done on me because it is less invasive and it's going to win. So that's one. The second component of your question, which I got, was, should every woman feel this labor pants? If I come and I twist your hands, you're going to feel pain. Now, imagine breaking 6 of these your bones consecutively. That is what has been ascribed to be labor pain. So no woman is allowed to go through the process of feeling pain. So we don't allow, or we inform you on the choices of pain medications that are available, so that this woman doesn't go through this process of pain. Also, National Association for the Society of Pain, they've also said that 2 major components. We have the emotional component, okay, and also have the psychological component. These 2 components are what these patients go through. That is why the onset of maternal post-maternal depressions is on the rising. Okay, childbirth morbidities as well as mortalities are rising because we allow these women to go through pain, whereas there are options for these women to feel this pain and have a smooth delivery. No woman is allowed or expected, in the sense of the world with the advanced medicine, is allowed to go through this process of pain. There are stopgaps to palliate, ameliorate the pain patients are going through.
All right, Doc, thank you. So good to see you after a long time. I just wanted to ask, I understand that the level of pain differs from women to women. Are the factors, that necessitate different pain levels for women?
Yeah, good to see you. Okay, so the published documents as to why different people feel different levels of pain, logic, and number 2, they are pathologic. So for the physiologic ones, we have the age of the patient, previous exposure to that particular pain, the race of the patient, the ethnicity of the patient, the cultural beliefs of these patients. These are the things that physiologically says first between me and you at the moment. If I hit my leg against a brick wall, the level of pain that I'm going to feel, it's either because I have had that experience before, in my brain response and say, this pain is not so bad as to kill you. Pain secretes what we call these endorphins, okay? Chemical neurotransmitters that we say don't feel the pain too much, because I make sure that you don't feel that pain.
Hello, Doc.
Levels of pain. Okay, we also have the pathologic reasons why pain differs from person to person. Okay, this pathologic reason, I don't want to bore you with too many medicalese, but the etiologic reasons why patients feel pains. Okay, we have the hyper, which means that when you have a sensation, response to that sensation is not like the sensation you're feeling. Okay, we call that hyperalgesia. So there are a lot that exists. There's another one we call allodynia. Okay, you have an insult, but your body does not see that as a reason for you to move your feet away from fire. So you can see people trying to put their hands into fire and it's not burning them because sensitized. Okay, the signal does not move from the skin where there's going to be elicitation of that you're supposed to have. So these are the reasons why different people feel different ways.
All right.
Quite interesting though.
Doctor, you mentioned two very interesting medical words as to the reasons why experience different levels of pain. You mentioned the physiology, pathology, or pathological aspect. But my question to you really is, what is the physiologic, or let me put it this way, what happens logically in a woman's body when she goes into labor? What are the things actually that, these pains in the women?
Very much. I try not to say so much medicalese, right? To understand for the purposes of our viewers.
That's all right.
So we have 1, 2, 3 stages of pain, labor pain. Okay, stage of labor. We have the second stage of labor and the third stage of labor. Now, the first stage of labor is when the cervix of the woman is between 1 centimeters and 4 centimeters dilated. Okay, and the transmission of pain from the lumbar region between the level of T10 to L1. Okay, the 10th to the first lumbar region. That's where this woman feels this pain. Okay.
Should this be the area around the waist or just
yes,
below?
The woman feels the pain between the middle part of her belly. That is when the woman tells you, "Oh, I'm having tummy hurt," and then the pain is usually like generalized from the umbilicus. Okay, that's the first stage of labor. The second stage of labor is when this woman is between dilated to 10 centimeters dilated. So what now happens is that this baby has moved into the birth. So this woman now begins to feel this pressure effect and pain more at the pelvic region. Okay, the lower abdomen and her pelvis towards our region, because the head is trying to impact and so that it opens and the head can come out. So at that point, second stage of labor, until the child comes out the birth canal, which is usually the vaginal orifices, and you have a baby. Now, when this is out, okay, there's something that this baby is inside, okay, which we call the placenta. So we now this placenta after we have cut the cords, because the baby gets its nutrition through the placenta cord center. The baby gets nutrition, excretes is through this placenta. So you have to cut the placenta so that this baby will now be free its own, no longer dependent on the mother. Now, labor is that this baby has been in a sac, which was the womb. Okay. Now, because of the size of this baby, physiologic changes that has happened in this woman, the womb has ballooned. Okay. But that is not the normal size of the womb. The womb be this size, this small. Okay? So with the baby, the womb this small again. So we now give drugs, okay, such as oxytocin, okay, so that this woman can contract the womb and all of the blood that is there. If this woman does not do that, woman is going to go into what we call postpartum hemorrhage, and she's going to bleed out to death if you don't stop that. Because the normal physiologic change is that at birth, there is increase of the blood flow of the woman to the womb. So this woman is neonates. If 40% of the entire blood volume is coming into that womb, is stopping it from coming out, the woman is going to sanguinate and die. So these are the stages of labor. Now this woman feels pain, the first stage of labor down to the third stage of labor. So these are the physiologic changes that happens when the woman term and is ready to deliver a child.
All right. I was just going to ask you, in your response to one of your questions, you mentioned of pain. I'm wondering, what are their mandates about this pain, so-called? Is it just targeted towards women who are generally medically?
No, pain generally. It can be pain from cancer, it can be pain from surgery, it can be pain. It's pain generally. There's an international association for the Society of Pain. They study pain at different levels. There are two types of acute pain for lay purposes. There's acute pain, chronic pain. For our educated viewers, we have what we call receptive pain, and we have what we call neuropathic pain. There's cerebral pain and there's somatic pain, but these ones are just medicalese. But for the purposes, we have two types of pain. Acute pain, any occurs immediately, less than 14 days is acute pain. Any greater than 14 days to 3 months, we call that chronic pain.
Okay, doctor. So I have two questions for you. You are able to take those two. Still on the issue of the core pain, since it seems as if pain has become and to have an association attached to it. So my question is, pain from childbirth, not hemorrhage or any other complication, but can pain in childbirth directly kill a woman? That is one. Secondly, we know, and you've alluded to that fact, that it attaches to the mother in the womb through the placenta. Now, administering Analgesia to the mother, does it have any side effects or complications, knowing that the baby is still attached to the mother at that point?
All right, thank you from the last question and come forward. Are there complaints that arise from the administration of this pain medication? Yeah. That is why the world is moving from administration of agents. Systemic agent means you get a vein, you put a cannula and a drug. Most of these drugs that are potent enough for the pain of this woman has the ability to depress the respiratory function of the child. So when you bring out this baby from the mother, the baby becomes, okay, that's when you have a floppy birth. Okay, you now have to start to treat drugs like naloxone to antagonize the effect of the drug that you have given her. Now, the happy side of epidural in labor is such that it has minimal or no effect on the mother. It goes directly to the junction box of where the pain is coming from and numbs it off completely. So that is why it is being regarded today as the gold standard, the management of obstetric pain. Your first question was saying, can pain affect the child? Of course, yes, the pain can affect the mother. Okay, the world today, the sixth vital sign is that tells you how important. When the patient is feeling pain, it tells you that there's imminent danger, there's a problem going on. Albeit labor is a physiologic, if the pain that you feel can move from physiologic to being pathologic. It's pain would obstruct wound healing. The affectation of pain is multi-systemic, from the brain to the heart, the respiratory, to the renal system, to the livers. It's multi. So pain can affect everything in a patient.
But can
Okay?
pain kill? I think that was my first question. Can pain directly woman in labor? Maybe she could not manage her pain and shot above her normal pain threshold and she gives up. Can pain kill birth? We are not talking complications now.
Yes, of course. Pain differently. Okay, there are reported documents where people have slumped. Okay, you just see them, they just, what we call maternal exhaustion, exhausted because of the stress of the delivery and the pain of the delivery. And then you have maternal exhaustion. You now have to bring all the armamentarium function. Yes, of course, pain can cause death. Yes, of course. Though small in terms of the general population, but there exist possibilities where pain can lead to death.
Okay, doctor, in your audience and expertise, what are some of the belief system and practices that have actually harmed progress, of using analgesia in treating? What are some of the misconceptions? If you can just be specific and name them, viewer out there can be aware.
As misconceptions are basically cultural, traditional. Okay, if you know people, I did National Youth Service Corps timing in the north. Okay, so in the north they tell you bear the pain. You are not supposed to feel this pain. So cultural belief. Okay, there's also this belief that people west of Nigeria cannot feel pain at all. And you see them shouting and yelling. Just anyways, you see them shouting and yelling. So there are cultural beliefs as people would not want to, take pain medical options where it exists. Okay, we also biases. Okay, also still on the same cultural. Tell you, oh, I gave birth to 7 children, I did not take any medications, why are you trying to medication? So they see cultural, ethnic and tribal. Okay, so these are just conceptions. Now, one of the medical misconceptions that people have, oh, if they give you this medication at your back, you're going to feel pain for the rest of your life. Conception. In the hands of the right provider, in the hands of the specialist, these complications are minimal or non-existent. Okay, they are just misconceptions that have been put forward. Other misconceptions forward is that, oh, once you have this epidural in labor, you are going to have a longer period of labor. There are still misconceptions. Study that there is no direct correlation between epidural analgesia, prolongation of duration of labor. There are no. Okay. Also, there are also misconceptions that once you do labor, you are going to end up as cesarean sections. There are also research that have been done to show that there is no direct correlation between having an epidural in labor and having to have cesarean sections. So it's men myth, unfounded beliefs that people have these things, but no, it doesn't exist in reality. Maybe in the last 1 month, maybe I've done, and I don't think any of them had any prolonged duration of labor. The point of the duration of labor is as a result of a problem that the woman has, as a result of poor dilatation, or what we call CPD, cephalic disproportions. Okay, so these are the reasons why this will be because of the epidural that they've had. So trust me, if you're coming to this, you're safe.
I hear you, doctor. So there's this that has been a subject matter for old wives' tales when women gather or talk about these things, and that is pitocin. What is pitocin and what is it used for exactly, to put fables?
They're actually not fables, right? They're actually not fables. It exists. Pitocin, they know as, in the public sense, as a genic agent. What this means is the drug that causes you to contract, as I was saying, in the third stage of labor. Once yours does not contract, the likelihood of you going in postpartum hemorrhaging is very high. We in the medical field will call pitocin. Okay, the brand name is called pitocin, heard in rural communities, or even in urban communities, people use the word pitocin, right? But the generic name is pitocin. It's a uterogenic agent. It causes the contraction so that the uterus goes back to the pre-conception stage, what it used to be for. The size of the uterus is just like a pea, a pear. Okay, that's how it's supposed to be. That's how big it's supposed to be. But because of the physiologic changes from estrogen, from progesterone, so as to meet the demand of this fetus, the uterus enlarges this uterus. Okay, so once it enlarges, and at the end of this gestation, it has to reach to its pre-gestational size. Okay, pitocin does. Now, pitocin is not supposed to be given of a lay provider. Pitocin itself can help to fasten the process of labor, but it is dosed. There is a dose that the obstetricians will give in the process of labor. Okay, they can use it, apart from fastening the process of labor, they can use it to start labor, which we call induction of labor. They can use it to augment labor. Labor is slow, they want to fasten it, so they want the uterus to contract and push the. So these are the uses of pitocin, but it should be of a provider that knows the complications of.
Okay, Doc, I just wanted to ask this. What are to would-be mothers, especially the ones that are always anxious and the pain that comes with it?
Okay, thank you very much. The advice I'll give to them, number one, once you are a childbearing age in seeking for a child, the first is to visit your obstetrician gynecologist. Okay, these are the people who know exactly what you should do before you get, while you are pregnant, and after you're pregnant. Okay, give you the options to come see people like us who are obstetric anesthetists, the options that you have for pain during the process of childbirth. So if you meet your obstetrician in your primary health, in your secondary health centers, or you want to go to a tertiary health center you have like two in Enugu, you have the University of Nigeria Teaching Hospital, Enugu State University Teaching Hospital, Parkland. So you have an array of brilliant physicians over there, obstetricians. Go to meet them. They are going to guide you through the entire process from to intraconception and then to post conception you need to do. So these are the people that are saddled with the task educating women on maternal health implications, the side effects, and the reason and the attendant complications post delivery.
Okay, doctor. We've heard of alternative pain management. They are not so popular down here, but Of course, you hear people puncture, water therapy, birth in water, large water canisters, women, birth inside. So I'm a bit curious, what are some of the alternative pain techniques are available down here, and would you actually to maybe would-be mothers?
Thank you very much. As a physician, I know that the types of analgesia and label, we have the non-pharmacological component and the pharmacological component, all right? The non-pharmacological components, we have things like acupuncture, we have things like back massages, we have water bath deliveries, which we call the doing. We have all of those. However,
okay, Doc, can you add a bit?
Sorry?
Can you adjust your phone a bit? We're losing your head.
Yes,
okay,
absolutely.
Good
you
enough.
look good. Yes.
Okay. The thing is that the safety and effectiveness of these animals are not there. They're not effective. So you know that science is an evolutionary. This was how we started. We started with the non-pharmacological processes, puncture, what we call TENS, okay, trans-electrical nerve stimulations, the acronym TENS. We have back massages, we have support, we have family support. All those things have been proven to be effective methods of analgesia. They're not effective analgesia. The effective method, which is today added to as the gold standard for analgesia, is the epidural analgesic label. Okay? That is where we give you what anesthetic agents through a small thread or a catheter, and then it delivers to the exact junction boxes where these pain nerves are found. So it goes there, it baits those nerves, and it stops them from transmitting signal from the uterus down to the brain, halts it. So that's why we still stick to the gold standard. Consultants, I'm a specialist. I wouldn't recommend non-effective, non-safety measures. I would recommend effective methods of analgesia, which today what we do is the analgesia.
Okay, that is insight. I'm also very curious as to know, is a possibility for some women to opt out of pain relief or management, management, because there are some women be very lucky, for lack of a better word. They just once ensues, before you know it, they have given birth. So they really do not have need for pain management. So is it possible? And in what scenario can a woman or a patient relatable partner say, hey, doc, can you take this out of the scene? Or maybe we don't even have enough money to pay for, the anal. So have you experienced this kind of scenario? And if you have, how are you able to manage it?
Oh yes, we've had a lot of them. We've had a lot of cost still remains one of the problems of healthcare delivery in Africa, to be specific. For labor analgesia, the entire path from hospital to hospital is ranging between 5,000 naira to upwards of #1 million, okay, depending on the facility you have gone to seek this level of care from. Okay, we've also had patients that are very modest incomes, need pain medications. Part of our corporate social responsibility that we've done over the years is to rally around and see how much we can help. But again, the funding is not so much, so we still have to go through this level of pain. because of their fetus at the time of them trying to deliver. Now, some, like you also, some women don't really go through this pain process for so long. Okay, those women, some of them have what we call precipitous. Any labor that starts and ends within an hour is called labor. So most of these women don't feel this pain because from when the pain, when they are like 2 centimeters dilated to when the fractured from them, it's just short, 30 minutes, 45 minutes, 1 hour. I don't really know what this pain thing we're talking about is. We've also had patients that from the time of labor to the time is 8 hours, 6 hours, 12 hours, okay? This pain medication, these are the group of people that are in need of labor pain because you can't just keep a woman, for God's sakes. You can't just keep a woman for 6 hours without any form of analgesia. Okay, I think that is barbaric. I think that is highly unacceptable in this present day and age that you allow women to, go through these processes of pain. I don't think it is as this current generation where we have the modalities to actually treat pain. Don't do it. So I think it shouldn't be done. It shouldn't be said. Government needs on these processes such that these will be included in the antenatal packages that these women will get, have a smooth sail at the level of delivery of their.
All right. Thank you so much, Dr. Ojebo, for your insights on today. It's been one very fantastic time with you in the last 45 minutes. Thank you again.
Thank you very much for having me.
We're headed for a short break. When we return, we'll switch gears for another discussion. So stay with us.